Hi everyone! Today we are going to see about the face and the skull. So now let's see about the face. The face is the front region of the head in between the ears and the hairline of the chin. When we consider the skin of the face, it consists of numerous sweat glands as well as the sebaceous gland. There are no deep fascia in the face. That's why we are able to show our facial expression. The muscle of facial expression are derived from the circumpharyngeal arc and they are supplied by the second arc nerve, that is the facial nerve. So in this face section, we are going to see about two main important things which are frequently asked in essays as well as in vivas. They are the blood supply as well as the nerve innervation. So now let's see about the nerve innervation. So when we consider the nerve innervation, the motor supply is by the facial nerve and the proprioception is by the trigeminal nerve. So now let's see about the motor supply, which is by the seventh cranial nerve, that is the facial nerve. The facial nerve has intracranial course as well as the extracranial course. The intracranial course will be covered in the neuroanatomy. So now let's see about the extracranial course of the facial nerve. The facial nerve, which emerges through the base of the skull through the stylomastoid foramen, gives out a posterior auricular branch behind the ear to supply the auricularis posterior as well as the occipital belly of the occipital frontalis. It also gives out muscular branches to the posterior belly of digastric as well as the stylohyoid muscle. So it is commonly asked in MCQ, the digastric has two bellies such as the anterior and the posterior. The anterior belly is supplied by the nerve to mylohyoid and the posterior belly is by the facial nerve. So you have to be concerned about that. Then the facial nerve reaches the posterior medial part of the parotid gland. The parotid gland is located here. So within the parotid gland, it is found superficial to the retromandibular vein as well as the external carotid artery. Within the parotid gland, it gets divided and then forms a network and finally it gives out 5 branches. The course of the 5 branches can be shown by the fingers like this. The temporal branch, the zygomatic branch, buccal branch, marginal mandibular as well as the cervical branch. So when we see the temporal branch, it emerges through the upper border of the parotid gland and passes across the zygomatic arc to supply the frontalis muscle of the occipital frontalis as well as the auricularis anterior and auricularis superior. The frontalis muscle is responsible for the wrinkling of the forehead. So when there is any damage with the temporal branch, the wrinkling of the forehead will be absent. So the next branch is the zygomatic branch. It also passes across the zygomatic arc to supply the orbicularis oculi. The orbicularis oculi is the constrictor muscle of the palpebral fissure. The orbicularis oculi consists of 2 parts such as the palpebral as well as the orbital part. So when there is any constriction with the palpebral part, there will be only a gentle closure where the eyelashes won't be buried like this. So when there is any closure, when there is any constriction of the palpebral as well as the orbital part, the closure will be forcible and the eyelashes will be buried like this. So during the closure, the eyelids will be closing from the lateral to medial part, by which the lacrimose secretion will be spread along the medial part. So when there is any damage with the zygomatic branch, as it is on the periosteum of the bone, it is high prone to get damaged during any fractures as well as in surgeries. So when there is any damage with the zygomatic branch, the orbicularis oculi muscle will be paralyzed, by which the blinking will be absent and the spreading of the lacrimose secretion won't be taking place. So therefore the cornea dries up, ulcerates and finally the vision will be impaired. And the next branch is the buccal branch. It gives out 1 above and 1 below the parotid duct and it supplies the buccinator and the nose muscle of the nose and the muscle of the upper lip. The buccinator muscle is important for the mastication. So when there is any problem with the buccal branch, the buccinator muscle will be paralyzed, by which the bolus will be lodged here in the cheek and therefore the buccinator muscle won't be able to push the bolus into the molar teeth for the grinding. So therefore we have to carry out the chewing from the opposite side. And the next branch is the marginal mandibular branch, which goes along the lower border of the mandible. So it is high prone to get damaged during any incision made in the submandibular gland surgeries. So when there is any damage with the marginal mandibular branch, the depressor muscle of the lower lip will be paralyzed. Because of that, The mouth angle will be asymmetrical during speaking or during smiling. And the next branch is the cervical branch. It goes along the lower border of the parotid gland to supply the platysma, which is responsible for the opening of the mouth. So that's all with the facial nerve. So now let's see about the proprioception, which is done by the fifth cranial nerve, that is the trigeminal nerve. The proprioception of the face is done in 3 zones by its 3 branches of the trigeminal nerve. This zone, which consists of the tip of the nose, side of the nose, and the upper eyelid region and the temple region, forehead region, is supplied by the ophthalmic nerve of the trigeminal nerve. And this region, the part of the nose, the cheek region and the upper lip region, these are by the maxillary branch of the trigeminal nerve. And the lower chin region, lower lip region and the cheek and the part of the pinna, these regions are supplied by the mandibular branch of the trigeminal nerve. So here we have to consider when there is any herpes zoster or any hemangioma which affect the trigeminal ganglion, their distribution will be like this, like the sensory supply of the trigeminal nerve.
This picture shows how the facial nerve emerges through the stylomastoid foramen and reaches the parotid gland, and then finally it gets divided into its 5 branches. The questions about the facial nerve are commonly asked by giving out the case scenarios rather than asking direct questions. So they will give out the case scenarios like there was a swelling in the left side of the face near the earlobe, or there was an infection in the parotid gland. There was a mastoid abscess and he underwent a radical mastoid operation. Something like that, they will give the case scenarios which are related to the cause of the facial nerve. So when these scenarios are given, they will ask like what type of nerve lesion is this, which nerve is damaged, and what is the extracranial cause, and something like that they will ask as the continuous questions. So while answering the questions, you have to be precise with the side of the nerve lesion and whether it is upper motor or lower motor neuron lesion. So very detailed information about the facial nerve palsy or the facial nerve lesion will be explained in the neuroanatomy. So when we see this picture is usually put in the spots. So you have to find out which nerve is damaged or which side of the nerve is damaged. Something like that they will ask in the questions. So when we see here, the ringling is found in the left side while it is absent in the right side. With that only we can find that it is the right side lower motor neuron lesion of the facial nerve. So to confirm this condition, while we see the mouth, it is deviated to the left side. So when there is any buccal branch damage or the lower motor neuron lesion of the facial nerve, the mouth will be deviated to the opposite side of the side which is affected. So the right side is affected and the mouth is deviated to the left side. So with this we can confirm it is the right side lower motor neuron lesion of the facial nerve. So something like that they will ask the question. So you have to be very precise with the side as well as the whether it is upper motor or lower motor neuron lesion. This shows the course of the branches of the facial nerve. The sensory supply of the face and scalp is shown in this picture. Let's see about the blood supply of the face. The blood supply of the face is mainly by the branches of the external carotid artery, such as the facial artery as well as the superficial temporal artery. The facial artery hooks upwards from the lower border of the mandible, which is anterior to the facial vein, and this makes an important spot. And the facial artery is found to the anterior border of the masseter muscle. The facial artery goes in a tortuous manner to reach the medial angle of the eye. It gives out supralabial artery for the upper lip region and infralabial artery for the lower lip region. The supralabial artery also gives out a septal branch for the nasal septum. The superficial temporal artery gives out a transverse facial artery for the cheek region, and it is found above the parotid duct. The ophthalmic artery, which is a branch of the internal carotid artery, also gives out the supratrochlear artery as well as the supraorbital artery, which supplies the forehead region. The supraorbital artery undergoes an anastomosis with the superficial temporal artery, by which the internal carotid artery as well as the external carotid artery undergoes a communication. When we consider the venous drainage of the face, the forehead region is drained by the supraorbital vein as well as the supratrochlear vein, and they both drain into the angular vein, and it will be drained into the facial vein, which has a straight course behind the facial artery. The temple region is drained by the superficial temporal vein, and it will be drained into the retromandibular vein. The region behind the ear will be drained by the posterior auricular vein. The retromandibular vein has its anterior branch as well as its posterior branch. The anterior branch along with the facial vein will be drained into the internal jugular vein, and the posterior branch along with the posterior auricular vein will be drained into the external jugular vein.
The deep venous anastomosis in the face and their connection with the cavernous sinus, as well as the infection caused in the danger area of the face and the consequences due to the thrombosis of the cavernous sinus will be covered in the cavernous sinus section. So now let's move to the skull. As the name implies, the composition can be denoted according to its name. The S for the skin, C for the connective tissue, A for the aponeurotic layer, L for the loose areolar tissue, and P for the pericranium. The skin of the skull is the thickest one, and it is more thick in the occipital region. The hair follicles as well as the sebaceous gland is more in the skull. And when we consider the connective tissue, it connects the skin to the aponeurotic layer very firmly, and the blood vessels as well as the nerve is found in this layer. And when we consider the aponeurotic layer, it consists of muscle at the front as well as in the back. At the front is the frontalis and at the back is the occipitalis, and they are connected by the epicranial aponeurosis. And the muscles are supplied by the facial nerve. As we have already seen, the frontalis is by the temporal branch and the occipitalis is by the posterior auricular nerve. And now let's see about the loose areolar tissue. Above this layer, the scalp can be moved. The scalping is done in this layer. This layer is considered as the dangerous area because if there is any infection in the subaponeurotic space with a pus collection, it will be spread to the intracranial sinuses due to the emissary veins which are valveless. And if there is any bleeding underneath this layer, the blood will be accumulated in the eyelid region as the subaponeurotic space is extended towards the eyelid. So due to this, the eye will look like the black eye. And the next layer is the pericranium. It is the periosteum of the vault of the skull. This layer is loosely attached. Because of that, due to any hematoma, the layer will be striped out. And as they are firmly attached to the sutures, the hematoma will be confined to that bone. So that's all with this skull.
This picture clearly shows the layers of the skull. The S for the skin, C for the connective tissue, A for the aponeurotic layer, L for the loose connective tissue as well as P for the pericranium. This shows the black eye appearance which is due to the bleeding underneath the subaponeurotic space which extends until the eyelid. Let's see about the blood supply of the scalp. The blood supply of the scalp is by the branches of the external carotid artery such as the occipital artery which supplies the region at the back of the scalp up to the vertex, and the posterior auricular artery which supplies the region behind the ear, and the superficial temporal artery which supplies the temporal region. And it is also by the branches of the internal carotid artery such as the supratrochlear artery as well as the supraorbital artery which supplies the region from the front of the scalp up to the vertex. And all these arteries undergoes an anastomosis. We have already seen that the scalping is done at the loose areolar tissue layer. So when the scalping is done, the bone won't undergo any necrosis. It is because the bone is mainly supplied by the middle meningeal artery. The veins of the scalp run back along with their artery. So when we consider the front region, It is by the supraorbital vein and the supratrochlear vein. They both drain into the angular vein and it will be drained into the facial vein. And the superficial temporal vein will be drained into the retromandibular vein. And the posterior auricular vein will be drained into the external jugular vein. And the occipital vein will be drained into the plexus around the suboccipital muscle, which drains into the vertebral vein. And that's all with the blood supply of the skull.
Let's see about the lymph drainage of the face and the skull. The lymphatic of the face is drained into the submental nodes, submandibular nodes as well as the parotid node. And there are no lymph nodes in the skull. The lymphatic of the skull is separated into two halves, the anterior half into the parotid node and the posterior half drained into the mastoid node as well as the occipital node. These all together drain into the deep cervical node. That's all with the lymph drainage. So now let's see about the nerve supply of the skull. We have already seen the proprioception phase is given into three zones by the three branches of the trigeminal nerve. And now the skull in this region, it is supplied by the posterior rami of the C2 as well as the C3, that is the greater occipital nerve and the third occipital nerve. And this region is supplied by the branches of the cervical plexus. That's all with the today's session. Stay tuned to Med Diaries for more videos. Bye bye.